Greetings, everyone. I am here with Jan Blanchard from PCC, who many of you know, to talk about the 2021 E&M updates. This presentation we're about to do is going to be a quick overview of the changes that are scheduled for January 1st in our little world. As a result, though, the fact that not everything is known yet, this little conversation is going to have a lifespan of 2 or 3 months. So Jan, you and I have to remember to take it down. But Jan's going to start off by walking through the coding changes, and then I'm going to, after heckling her throughout, I'm going to walk through some of the RVU impacts. We don't normally do a presentation like this, especially together, for a variety of reasons, not the least of which is Jan would prefer not to have me on stage with her. But this is a really big deal, and we don't want to miss the opportunity to help get people prepared for this. I think especially coming out of COVID, everything that we can do to get practices prepared for change is a big deal. So Jan, why don't you walk us through what is going to happen to our favorite set of CPT codes, the 9921 and 20 crowd? Go for it.
I would be glad to do that. In essence, what we're going to do is just cover the changes to the way that the codes you mentioned, the E&M, just the outpatient E&M codes. Those are the only things, the only services that these changes apply to. This isn't, if you're one of the clinicians that does inpatient, outpatient hospital or ER services, these rules do not apply to those. The rules for those visits are not going to change at all yet. But so what we're going to go through today is just the outpatient sick visits, and there are 4 major changes that we're going to cover today. The 4th being the work RVUs and the conversion factor that you'll talk about later, Chip. But the big changes that are going to happen with leveling those codes have to do with which key elements are going to be part of your thinking when you level them. That's going to change. What remains as relates to what your leveling decisions will be based upon in 2021 and beyond, and the definition of time when you're using time to level your visits. So briefly describing each of those, the first of those being the medical decision-making, those key elements. So currently you're leveling your visits based on the 3 key elements as defined by AMA: history, physical, medical decision-making. For new patients, all 3 of those have to meet or exceed the level that you bill. For established patients, only 2 of the 3 have to meet or exceed the level that you bill. That is changing significantly. The only one of those 3 key elements that will factor into your leveling in 2021 and beyond is medical decision-making. So history and physical go out the window for documentation. Your documentation, of course, you'll perform those parts of the visit. We're not losing our minds entirely. You'll still practice medicine and write it down, but the only thing for leveling that's going to count is medical decision-making. And I'll go into the details of what comprises that remaining key element. The second big part of this is the complexity levels that you choose based on those medical decision-making factors do not ever have to meet the 3 of 3 rule. So I mentioned briefly just now that new patient visits for key elements in 2020, history, physical, and medical decision-making all have to meet or exceed. When we narrow this down for 2021 to just medical decision-making, the 3 sub-elements of medical decision-making only have to follow the 2 of 3 rule for any patient. So that's a nice relaxing of the standard. And the third of these big changes is the definition of time. I'm going to show you some details about how all clinician time on the service date counts toward your level choice. And that is a big change. I'm pretty excited about that one.
So let me ask a question, Jan.
Of course.
What is the intended purpose of these changes?
These were intended, these discussions have been going on for a while, and I think several attempts have been aborted at what they're calling paperwork reduction. So it's simplifying documentation and trying to take some of the documentation burden off of clinicians when they render services like this. So that is the overarching goal. That's one of the overarching goals. Another is to more equally apply the E&M concept to all specialties. So it kind of takes some of the variation probably is better than variance. Take some of the variation away as this one small set of 10 codes is used across every medical specialty in the U.S. So it levels that playing field some. Yeah, those, from my perspective, those are the two really big ones.
Yeah, I just found that I found it appears to be an interesting and actually earnest attempt to reduce both the time and subsequent emotional burden of using an EHR. That's like right out front. Like the amount of time, in theory, we're going to talk about this, but in theory, the amount of time you spend charting should decrease.
Mm-hmm.
And that is welcome news in just about any circumstance. So
yeah. Well, and the other bit that I really love is that it simplifies your decision making, your level choice.
Right.
There's so much less. You don't have to have all of the sub elements of history, and you don't have to do document a head to toe physical if the head to toe doesn't reveal anything that's meaningful.
It's not bean counting anymore. The whole point,
exactly.
The whole point is that it gets back to creating a chart note that is actually relevant to the visit, not a chart note that is required to support a certain CPT code.
Yeah,
and
it's less a legal document than it is medical documentation.
And hopefully what this means is we'll stop getting chart notes from especially some of these large system EHRs where you get a 30-page note, half of which wasn't even accomplished, let alone appropriate if it had. I mean, when you get the 12-year-old girls with undescended testes, that you've got a template situation.
Exactly.
This moves away from the template situation. And
bloat may become a thing of the past.
Yeah, let's cross our fingers, because let's be honest, the feds are involved. Anything can go wrong. But
Indeed.
At this point in our slide deck, we're optimistic. So let's see how that goes. All right.
We've only just begun.
Yeah, we've only just begun. Okay, Jan, take us through it.
Yeah. So to get into some of the detail of each of these, in essence, a level becomes a level becomes a level, because there is no difference across levels now between new patient and established patient requirements, because everything is, 2 out of 3 of those medical decision-making elements. A level is a level. All that you in essence can document the level of the visit, and then it's a matter of circumstance whether you use a new patient code or an established patient code. The level is going to be equal across those two code sets, those two subsets of codes. The level one, the nice thing about level one is that this makes it much more explicit that level one should never be used by the billing clinician. So if you are the MD, the NP, the PA, whoever's creating these orders and managing this patient's care, you should not ever be using level one. And you'll see in the full collection of codes, when you see the comparison of new to established codes, you'll see that more clearly. But this really just illustrates that levels are the thing. They're the difference or the choice between whether you need a more complex new patient visit code or a less complex established patient visit code. It's simplified just by that one factor. You don't have to care whether you've seen the patient before. You just document the visit, do what you're going to do, pick your level based on that.
Right. And we know, PCC knows that the average new level volume is about 3.5%. That doesn't sound like a lot, but that's about a kid every day and a half. And even though a bunch of those are well visits, it means a couple times a week, you're no longer having to figure out, this was a 99214, except it's a new kid, so it's probably a 99203. And so this is already just that simplification is something that's going to save you a little bit of time. It's not the big punchline, but it's a good one.
It's part of it. Yeah. Well, what I like about that too is anybody on your staff can look at the last time you saw a patient and determine without doubt whether they are a new patient or an established patient and change the code accordingly. You don't have to do the mental gymnastics to remember, is a 204 equivalent to a 213? Because maybe they were seen in the last 3 years. No longer matters. You document the level. Anyone on your staff can make the correction. It takes the judgment call out of the visit leveling. You're stating the level unequivocally as the clinician. Your staff can assign the new or established.
Yep.
Because that level won't change depending on that.
Yep. That's not a clinic. They're whether they are new or not is not a clinical decision.
Yeah, it never was, but because
Right.
it was not a parallel crosswalk across the new and established codes, there was the potential that if they changed it from established to new or vice versa, they'd have to reconsult with you.
Yep.
That won't happen. This simplifies that, streamlines it nicely.
Or worse, they didn't. Which
Exactly.
which is what we saw. We've seen plenty of times.
Yeah,
right.
where you give away new patient care.
Yeah.
So moving into the details of the medical decision-making sub-elements, this is just a brief outline of what those elements are. In essence, you're documenting the nature and number of problems that the patient has. You want to capture the source of data and how much data, like which history and test results and specialty consult reports, that kind of stuff, all of that data you want to capture in your note whenever something factors into your thinking, or even if you just research. All of your patient visit preparation can go into this too. So capture the data that you use to manage that patient that day. And the third factor of these three is the risk that is posed to the patient by the problem management that you come up with. The way that you decide to manage the patient's problems, whatever level of risk is inherent in that choice or those choices, is what you'll base the risk assessment on. And then again, I'm repeating here that 2 of 3 rule. Every visit may be leveled using just the 2 highest, whatever the 2 most complex of these 3 data elements is, that can determine your whole visit. So that's a really nice change. It's an easier target to hit than with the 3 out of 3 visits with the key elements as it is right now.
Yep. And no more body part counting.
Exactly. Oh yeah. You can
more...
do just the physical that you need to do, and I've always said, working with pediatricians, it's my privilege to do it. And it made my life easy as an auditor because I had every right not to question how many body systems you reviewed, because you guys do full head to toes every time. Because you are developmental health specialists, in essence, you know things adult clinicians don't. You look for things adult clinicians don't. They're not working with a patient population that changes as drastically as your patients do from visit to visit. So, physical was never a question for me. I never, other than the really absurd examples of, they came in for a foreign body in their thumb and you did a urogenital. I mean, come on. But in the cases where it was a systemic disease, you're going to look for clues wherever you find them. And you won't have to do that. You won't be as compelled. And even if you do it, it won't matter. You do what is meaningful to you and move on. All that's going to count is the medical decision-making documentation for this purpose. So the things that I recommend specifically for medical decision-making language, when we get into talking about preparing for this change, one recommendation I'm already making is that the language that AMA uses to describe each of these 3 things, the problems, the data, and the risk, familiarize yourself with that AMA language, because those are going to be the things, if you ever had to argue or defend an audit, these are the phrases that you're going to be asked to hold your documentation to. They're going to say, this is what qualifies for a level 4 visit, and this is what qualifies for a level 5 data. Those are the things specifically for the problems in data. Familiarize yourself with these things. The nice changes that I see in each of these, or the nicest change that I see in this set of examples, is in the data section, that center section. Each of the underlined phrases here points out something that I can give you credit for next year that I can't yet. And I'm dying. I can't wait to do my first 2021 audits, because I can give you credit for each and every test that you order. It used to be I could give you a maximum of 3 points for diagnostics ordered, I could give you 1 point for radiology, 1 point for lab tests, 1 point for medical tests. Now I can give you a point for each unique order and a point for each result that you review. But again, it has to be on that service date. And I'll get to a better explanation of the service date requirement. But everything that you review and order today gets you a point. And all of those things comprise the complexity of the medical decision making that I can say that your documentation supports. So I'm pretty excited about that change specifically. When it comes to risk, the shortcoming that will remain in the AMA definition of risk is that all that's available as far as guidance for what documentation has to include, all that's available for comparison is examples, clinical examples. So when you're looking at this list of risk phrasing, in order of increasing complexity, you're looking at adult medicine examples, which is frustrating to me. It is one of my big dreams to create vignettes and pediatric specific risk examples, ones that you guys can get behind and that you agree with. So someday when I take on that project, I'll collaborate with some clinicians and get that done. But in the meantime, what we've got to work with is just but mostly adult specific examples. Drug therapy requiring monitoring.
They're pretty black and white. They're like
yep.
going to the hospital, and it's like it's not
signing a DNR.
Yeah, right. And it's like, okay, yeah, those are pretty high risk decisions, but
right.
Pediatricians are often making risks that have much longer term implications than sending a kid to the ER right now. You know,
yeah.
If I don't, is this kid at risk of dying if I don't treat this otitis properly? No. But is this, I realize it's far-fetched, but is it possible that this kid risks losing his hearing? Let's just say. Yeah. And so you're exactly right that so many of the risk factors seem to be almost like end of life or, and they're also very surgery focused.
Yes. Yeah, the invasive procedures and the high toxicity treatments and
right.
Yeah.
And really what we're talking about is what happens to this kid over the next 20 years if I don't perform this work. And
right. And how do you express that for a single visit?
Yeah. And the thing is, it's coming. I am pointing out within our sort of poking at it so far, I am pointing out the softest spot, the one complaint I have. I've got a couple other little complaints too, but the rest of it, as Jan's pointing out, is fairly aligned with the way that you actually do your work.
Yep.
We'll talk about some examples in a little bit when Jan gets to it. And we don't know yet for sure, but it'll be nice when we could say, look, asthmatic comes in, you do X and Y and Z, it lines right up here.
Yeah. Well, this next slide is probably there it is. This is where the rubber meets the road. So you take those soft, squishy, qualitative sort of things from the last slide. This is where you quantify them. And I know this is impossible to read, and that's why we have the link for you to download this and review it on your own.
Right.
But
hit pause right now.
Exactly.
Hit pause. Go to that bit.ly. Bit.ly. It's bit.ly/AMA grid with AMA and G on grid, all caps. And so you can look at this while we're talking about it. And at first, it's a little. I saw this. Jan showed me this. I was like, oh my god, I'm gonna have to memorize something else again. It's actually not that bad. It really is not that bad.
Yeah. This is just the thing that tells you how to quantify the stuff from the previous slide.
And when you put your hat on and say, okay, let me think about my visit, my day yesterday. I saw that kid with X. I saw that kid with Y. I saw that kid with Z. You're going to realize things fall into buckets pretty quickly in a way that is very different from, well, that kid I had 5 ROS elements, and that kid I had 3 HPIs or whatever. I always lose track. This one is just a lot simpler. It's the problems, the data, and the risk. It's definitely a lot cleaner.
Yeah, we go from 7 things to juggle in your mind and compare and contrast to 3.
Yep.
And you only need 2 out of those 3. So the simplification bar has been reached, in my opinion. And like you said, it aligns much more closely with the work that you do. The really sick kids are going to have the really high codes. It's not going to be a case where mom took 45 minutes to tell you the history and started with the day her 16-year-old was born, and that is what determined your visit level. This is so much more closely tied to the real thinking that you do and how sick the kid is.
Yep. And it does mean, one of the things I find interesting about this is yet to play out. But there's no question, Jan, as you know, we have some clients like I've seen. I should do a study on this, but I've seen that we have clients who've been in practice for 20, 30 years, been in practice for a while, and they can crank out sick visits much more quickly than a newer physician. And they do so because of their skill and experience. Their skill and experience doesn't mitigate the risk. It doesn't reduce the risk that the kid presents with.
Right.
And it doesn't lower the problems that the kid presents with. And it may not even affect the data. It may or may not affect the data. Okay. But my point being, I've seen so many examples over my career of pediatricians who undervalue the work they do because they can spot a kid with strep across the grocery store.
Yes.
Right. And so they're like, well, that can't be a 214 because it only took me a minute to diagnose it.
Yep.
That's not the point. That's not the point. And in fact, just because you're good at it shouldn't penalize you.
Yes.
So that's one reason this excites me.
You and me both. I'm glad to hear you repeat that. It's something that I've been saying to clinicians since you offered that framing of it to me when I started at PCC. I mean, it just makes so much sense. Just like you say, just because you're good at it, just because you can take one look at a kid and know whether they have fever,
Right.
like children, what healthy kids look like. And unfortunately, what sick ones do too.
Yeah. And if it's your 8th one today who looks the same, and you're like, oh, GI, what's your middle school? Oh, okay. Yeah, I know what this is.
Yep.
Your risk is still the same. Your problems, the problems presenting are still the same. And potentially, if you're going to run a lab or something, that's the same. Right. And that shouldn't penalize you because
that's not a detriment. Right.
Right. And you don't, and then, okay, because what happens right now is a lot of doctors, there are plenty of you who do understand that and do say, yeah, I don't want to be penalized. So what am I going to do? I'm going to jump through this hoop where I click, 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 click. I did not exaggerate what I just did. And now I can get a 213. Now I can get a 214. It takes that game away a lot. And, so I'm excited by it. Anyway.
Yeah. And so the nice thing about that, this, like we said, this more closely aligns with how sick the kid is, but it doesn't take away. And these changes actually enhance your ability to use time leveling.
Yes. So
the changes that are happening to time leveling are really exciting to me. This is the part that I'm most fired up about. The really good news that I see here is the much, much greater number of your daily activities that can be billed for the patients that you work with, for working with the patients that you work with. So time becomes the way that you can level for any visit at all. That 50% of your face-to-face time requirement goes away. So everybody that's got that built-in statement, I spent X number of minutes with this patient today, greater than 50% of which was spent in counseling and discussion. There's a hoop you don't have to jump through anymore. Every visit is fair game for this type of leveling. What can be counted for your minute total has expanded significantly. Everything that you see on this slide is, and I have to come up with a better phrase than billable time. I feel like I'm talking to attorneys when I say that. Billable time is everything that you do for the kid before the visit. When I say everything in any context related to time in 2021, it's everything that you can't delegate. So if you schedule the appointment yourself, if you check the kid in yourself, if you're a one-woman show, that time does not count. So it's clinical activities. It's the medicine that you do and the decision-making, all of the preparation, the historical records you review, the lab results that you review, the triple checking, the clinician, the specialty reports and specialty correspondence, all of that stuff that you do to prepare can be counted. Nothing that you do during the visit goes away. You can still count all your face-to-face time, all the treatment time. When I say treatment time, I have to be careful because the things that can't be counted separately are the things that would land on a different line item on a claim form. So if you do, and if you do any type of therapeutic procedure that takes a bit, do not count the therapeutic time, that procedure time in your time total. This is strictly decision-making visit time. So it's conversation and it's history taking and it's planning and counseling, that kind of stuff. Not anything that's hands-on, not anything that's separately billable from the E&M.
But it used to just be counseling.
Correct. Yeah.
Yeah,
it was just the time that you spent in education and reassurance and Q&A, that kind of stuff.
One thing I like about this. All right, let's admit it. You and I can admit this because we're not doctors who've signed HCFA forms. The fact of the matter is, no one that I've ever been aware of has actually ever determined that counseling was being done when you submit that 40-minute 99215.
Oh, yes, they do.
Oh, no, they don't. I mean, yes, okay, they try, but the fact is, if you've got a mom who won't stop talking, that you would file that under counseling in the good old days, and it is, and it was.
It is.
Well, but if you're just shooting the breeze with a neighbor, okay, you would still look at that clock and be like, well, I can count up all these elements over here. I can look at now.
That's
it's
relationship building.
It's literally, though, they've sort of opened the door. They've said the time you're spending with the patient and the time you're spending working on the patient.
Yes. And on the case in total. So it's not laying hands. It's the time you spend on that service date. And that's an important bit too. Currently, the definition of what's billable is limited, strictly limited to only things that are done on the calendar date of the encounter. I'm really hoping that some guidance comes out and soon.
Yeah, we've come up with like a half dozen scenario questions. We're like, you do a phone visit or not, or even if you do a visit at 11:30 at night. Do you have 30 minutes to do this visit if you're going to record by time? So
to do everything, right?
Do everything. Yeah. And we really know. I mean, here's the thing. And this is what everyone's been asking about. Yes, it means the time that you spend charting. And the killer, every pediatrician I know tells me this, the stuff that drags, the stuff that you're doing when everyone else goes to bed, the stuff that you're doing when your family's watching TV and you're not, is when you're reporting a long mental health visit that has a giant narrative. You spent 30 minutes in that exam room and you spent 20 minutes typing up the chart note and you could only get a 214 as a result. All right. And I mean, Jan, you and I have heard that a million times. And then now spend that 30 minutes in that exam room, spend that 20 minutes charting on the same day. And you have that 214 just like that. And maybe even, as Jan will show you in a second, a 215. There, it was a little bit harder. And that's gigantic.
Yeah. So as we're going through, as recommendations go, if your notes, if the way that you record your notes right now doesn't lend itself to capturing all of these activities, that's something that you want to take a look at. You want to make opportunities for yourself and make them where they make sense to you. Put tools in your encounter records where you are most apt to remember to record this stuff and that you'll have the best recollection of them.
Couldn't agree more. I think that's great.
Yeah. I mean, capture it. They're giving it to you. Take it.
Well, yeah, what we're wondering is, as it relates to Jan's comment about guidance, is what do we do about that visit where you run a bunch of labs and the lab stuff comes in 2 days later or a week later, and you've got to call the family back and have an interaction. It would be really cool. And it sort of seems like the direction we're headed in is the follow-up time you're doing with those labs could be added to this date of service. But right now, that's not the case.
Right.
My guess is, and I say this because the advantage of not being a certified coder is I can say whatever I want, all right, and be easily dismissed, but I don't like betray my education. And so, because I have none, I think one of the things we're going to see here, Jan, is because we know E&Ms, I haven't sprung this on her yet, because E&Ms technically do not need to be face-to-face. I suspect the way this is going to get pushed on is kid's going to come in for a sick visit, a bunch of labs or referral work is going to happen or whatever the case may be after the fact. And someone's going to have the bright idea, oh, I should just bill another E&M today because I spent 30 minutes on the phone talking to a specialist, doing some clinical stuff, whatever the case may be. I just did a bunch of work for this patient unpaid, which everyone listening to this does every day.
Mm-hmm.
And why not file another E&M? And Jan is on this, seminar with me because she will tell me why I'm wrong. But we know that, that's where the pressure is going to come from.
Yeah.
My guess is the people at CMS and the AMA, they know this, and they just know that that's too big a leap, because when we get to what we get to the impact of this in a few minutes, you're going to see why. There's some interesting. This is headed in the right direction, and I'm hoping what this means is that you will start to get paid for all of your time, all of the time you spend doing work.
Yeah, I'm hoping that the definition of an episode of care is malleable enough and can be applied to proper payment for the work you do.
Yep.
It's got to be.
Yep. All right. Sorry.
Yeah, no, that's okay. So when you come up with that daily total, the total that you spent with that patient that day, wherever that total falls into one of these time ranges is how you're going to choose your visit. So you've got your new patient visits on the left, you've got your established patient visits on the right. Those look daunting. If I hadn't already told you the good news about how many more of your activities, your daily activities with each patient can be counted toward these totals, this could be daunting. Chip and I were talking through some vignettes the other day. It does not seem out of the realm to me for a relatively moderate complexity visit to stretch into 99214 time, into that time realm. Mm-hmm. It doesn't seem as out of reach as these numbers might look. And I'll be surprised if people are really struggling. If you spend 10 minutes reviewing a complicated case and refamiliarizing yourself with it for a kid that comes in with 2 or 3 different problems that him and his parents all want to talk with you about, you could have a 20-minute visit, 5 minutes, 5 to 7 minutes of review ahead of time, and another 5 to 7 minutes of orders and referrals on the back end. You're in 214 territory. It's not out of the realm. So
right.
when we really look closely at it, these things don't really look like much of a stretch. That not a huge difference from that.
And we were bouncing vignettes back and forth. I'm like, well, what happens when this asthmatic comes in and then this and then this? And I'm like, oh, well, now we have it on medical decision making.
Exactly.
So,
yeah.
I find that we're not done with our work. There's a lot left to do here, but I very subjectively in our brief period pushing that on this, I'm like, there are far fewer holes in this. Mm-hmm. Because there's this aspect of coding, as you know, Jan, where, and you've been told this 1,000 times, well, I know when it's a 2 and 4, and I know when it's a 2 and 3. And I'm not a big fan of that because the rules up through the end of this year are pretty prescriptive. Like it's like, you can't just have a feeling. All right. And you and I have also heard coding, I'm putting this word in quotes, experts say, well, when it's a 2 and 4. And I'm like, well, you should know because you followed the rules on it. Well, and my point being that I'm familiar certainly with enough cases of people who would say to me, oh, I can get a 99214 out of a otitis recheck. And I'm going to say on one, I think this is a good thing. I don't think you can unless it really deserves it now. But what it means in exchange is that all those other visits In fact, the visits that where you're doing your best work, because when you turn an otitis recheck into a 2 and 4, you're not being a good doctor. Period. Fight me on it. Okay, you're just not. You're not. But when you're spending that extra 10 minutes because you've connected with a teenager and you're really starting to get through it, or you're helping them find the resources that they need, or you pop out of an exam room to talk to another doctor to do something, all that stuff, that's the work that you really need to be paid for. And Jan and I couldn't find a lot of immediate examples where you were going to be doing good work and it wasn't going to either get picked up by the MDM or the time.
Yeah, it all fits pretty well.
Yep.
There weren't any outside of tricky recording things like modified visits. If you've got a modified sick with a well, you're going to have to be really explicit about recording, drawing that line in the sand and saying, I did all of this, and then we talked about the problems or concerns that mom and dad raised.
Right. Except we don't have to worry on the flip side of that, as you and I discussed. You don't have to worry now about accidentally borrowing too much from like the well exam or the physical exam part of the well.
Right.
Which is, I mean, you and I have seen people get burned on that all the time. Like,
oh yeah,
double dipping. So you can only double dip on time now.
Right. Yeah, because the medical decision making is just not going to be a part of the well care.
Right. And so I think personally, given the level to which a 992 and 3 is very achievable, I think that very achievable with a normal presentation of a sick kid. That's what I mean to say. I think anytime you've got a kid comes in for a well exam and you're looking at something else that could have necessitated a visit, that 2 and 3, 2 and 5 shows up with the smallest bit of effort. Now, everything I said up until the smallest bit of effort was true it's true right now. Kid comes in for a well visit and he shows up with presenting something that could have necessitated a visit. That's what the 2-5 modifier is for. Mm-hmm. But so many of you skip it, and one reason people skip it, besides getting paid poorly for it and all the shenanigans from the insurance companies, the other reason is because it's a pain. Oh, I've got my EHR doesn't support doing this well, or I've got to separate this visit and no. Guess what you do now? It's like you just either count those specific minutes spent on that, all of that, or you have your MDM. It's easy. Yep. So we'll see if that's right. But
yeah, so much less threat of double dipping unintentionally. Yep. That 99% of that goes away.
Yep.
The other notable thing about the codes themselves is that 99201 disappears entirely. That has an expiration date of 12/31/20. It only differed from 99202 in the history and physical realm. So because those are disappearing from E&M altogether, that made 99201 and 202 identical. So for our purpose, it will no longer be needed, and it will, like I said, expires at the end of this year. 99211 should never be used by you. That's staff time and staff carrying out orders under your direction. If you even stick your head in a door, you even lay eyes on and have just a brief conversation with the patient, 212 is the very, very least you should be billing. 211 does not involve you at all.
Yep.
The prolonged care codes have been revamped for 2021. I have not done a proper assessment of them yet. It's killing me. My CPT manual arrived and I have not yet been able to crack it due to other work that I've been doing. It's killing me. I'm surprised you didn't
call in sick today. Oh, I'm going to be sick.
Oh, well, you don't know what I was doing on Monday. My pen ran out of ink while I was doing it Monday. Oh, okay. But in future events and future materials, we will definitely do a deep dive into how to use the 2021 prolonged care codes. As expected, they will only be used for 205 and 215 that have been leveled using time. It will become much less, it's all but meaningless to tack on a prolonged care add-on code to anything else, right, simply because the typical duration, the whole idea of typical duration goes away. It's these very prescribed time ranges from here on out.
Yeah, to me, this is just an additional simplification. This is what happens if you spend more than an hour with a kid.
Right.
And that is in fact a fairly uncommon occurrence, but they have you covered. Whereas before there was always like the idea of using a 99213 in a prolonged code. It was always like, which we have seen. I'm like, that makes no sense to me.
Well, it makes sense to coders.
Right.
There absolutely was a place for it, but it wasn't an easy.
So unlikely though.
There were no rules of thumb
Right.
for it. It was just not intuitive. It wasn't an intuitive approach to leveling. So it or to using that add-on code. So it's nice to see that go away.
All right.
Yep. I cannot say enough about the AAP coding newsletter resources that have gone into exploring all of these concepts. They've taken their feature article each month and dedicated it throughout this entire calendar year to bits and pieces of each of the things that we've talked about already. So if reading and having something in your hand makes these easier to commit, go for it. If you're not already a subscriber, please don't wait. These honestly, I've been using them as my own Bible and triple checking myself with them because they're just that good. They go really deep in some of this stuff.
I think this is the new Netflix right here because you can binge watch the AAP stuff. I mean, because you look at it right now, you're like, September. They haven't even gotten to level 4 yet. So
how many episodes are there?
Yeah, exactly. They did such a good job at this, and of course, it was a little disheartening in some of our various groups to have people saying, "Well, what's the AAP doing? I haven't seen anything." And it's like they have been doing this work.
They have. They hit the ground running in January with this stuff. Right. This was long in advance of when you guys would need it.
Yeah, I think the AAP coding people are doing their best work right now, and so I'm actually kind of excited to see the next episode, October, because now that's really going to start zooming in on the meat of stuff. I mean, look at the order they did it in. They are ending this season on a cliffhanger. So
this is really, really well planned.
Yep. So good for them. I think it's exciting.
Beautifully executed. So so that's the coding and documentation side of it. So there's more to it than that, of course, as we alluded earlier. Yep. This is the other part of it.
All right. Here's the ugly numbers part. Now, if you're just listening, as many people will, I'm going to do my best to illustrate what we're about to talk about verbally, but we'll see what happens. So here's sort of the curveball to this entire discussion. It'd be one thing if the feds just rolled all this out without making any changes to the E&M values, but they are, and they're making actually, frankly, huge changes. What you have here, okay, if you look at the spreadsheet or the little table in front of us, we have 4 CPT codes, 99212 through 2 and 5, and Jan and I put in a distribution value for an average PCC client of an average volume. So what that means is an average full-time pediatrician for PCC does about 3,200 sick visits in a year, okay? And they're distributed with 5% 2 and 2, 62% 1 3s, 30.5% 2 and 4s, and 2% 2 and 5s. So it's right there on the screen. And then under the 2020 umbrella, you can see that the work RVUs for each of those procedures, like for 2 and 3, is worth 0.97 work RVUs. That's not the entire RVU value. Remember, you've got the practice expense part and you've got the malpractice part, but the work RVU value is in there, and you can see the total work RVUs performed with those E&Ms and what that's worth in Medicare dollars. Now, here's the thing. The feds are throwing like 4 curveballs at once at you with this. Not only are they changing the E&M rules, but they've massively increased the work RVUs for each of these procedures by I'll give you the numbers in a second, okay? But however, at the same time, they've significantly lowered the annual Medicare conversion factor. Now, this is all just a preview of what we're supposed to get. None of this is official yet. And so on one hand, if we were to go into 2021 using the data that we know right now, we are looking at an increase, if nothing else changed, and all your payers followed RBRVS and were used 2021, this would, if your E&M distribution doesn't change and they just use the lower conversion factor, you're talking about an increase of about $23,000 per doctor, which is huge. Now, the thing is, there have been a few times in our past when the conversion factor has changed as large, or has faced as large a change as we're facing right here. In this case, it's about 12-13% drop. But it always gets fixed, because what that means, if they drop that Medicare factor from $36 down to 32, all the other specialties are going to complain. And I assure you, cardiologists do not care as much about what a 2 and 3 gets paid for as you do. All right. Even though they do them, they don't care like you do. All right. And so they're going to complain. And so if you just use this year's multiplier, then we're talking a $40,000 improvement to your bottom line. Now, I'm not suggesting at all that they're going to go back to the 3609 that we're using right now. In fact, I don't think they will. But I don't think, and I could be wrong, but I don't think they're going to stick with the 3229 that they projected. And frankly, we're just going to have to see what our legislature is comfortable doing in terms of increasing the Medicare budget, because that's what we're talking about here. This is a political issue. And so, all right, let's take a look at, Jan, next slide, please. Let's take a look at what this means for a bottom impact, okay? There's an average 31% increase in the work RVUs, and that's weighted by volume, okay? So on average, your work RVUs increase 31%. So that doesn't mean each procedure increases by an average of 31%, just the work RVU side, but that's a huge increase nonetheless. And so to put this in perspective, a 2021 99213 is worth 86% of what a 2020 today, a 2020 214 is worth. All right. Oh, do you see that where it says versus 85% on our slide? I realize that's a typo. That's supposed to say 65%.
Oh.
Whoops. All right. So it's 86% versus 65%. A 2021 214 is 90% of a 2020 215. So even if your E&M distribution slides, you're not sliding into oblivion. You're not dropping just a code. So literally, if your 2020 2 and 5 goes down to a 2 and 4, you're only going to lose that 10%, as opposed to dropping 30%. All right, which is what you would have lost this year. However, there is a 12% decrease in the conversion factor, which affects all codes. And I will be talking or posting on my blog or both about the overall RVU impact, like 3 days after the RVU file gets released. All right. It hasn't been released yet, so I'm not going to say anything official. And so we know that, I can tell you because I've cheated a little bit and I know a little bit between this change and the potential return to a partial improvement of the vaccine administration codes. Overall, it should be a pretty positive thing for pediatricians, but we don't know yet. We just know that it's going to have a significant revenue impact. All right, this is gigantic. So this is why you need to understand what's going to happen on January 1st. All right, Jan, let's go through this though. So I just have my caveats here. What we don't know yet is what the effect of the new rules will actually be on your E&M distribution. We have some guesses. Personally, I think 2 and 4s are going to increase, but who knows? Mm-hmm. All right. Especially who knows, because no matter what your natural inclination would be, we know that the private payers are going to beat you into some shape that they want. All right. Mm-hmm. So we'll see what happens. All right. We're only seeing the change to the work RVUs of a select set of codes and not the other two components of those codes or the other RVU values. The conversion factor cut, which is required to maintain budget neutrality, is going to decimate the rest of your procedures if that gets maintained. Of course, none of this is published yet, so who knows? We're just guessing. And here's the kicker. Most importantly, we don't know when, if ever, the private and public payers, except for Medicare, are going to start using the 2021 values. Very, very few private payers are using that current year's RVU values for
Yeah.
payment. And so every one of these factors is like strike one, ball one, strike two, ball three. These things are, and we just don't know what's going to make contact.
Yeah.
It's a
It'll
little,
be interesting.
it's time, because we needed a little drama. All right.
Didn't we though?
Yes. It's been boring.
Let's complicate something else.
Yeah. All right. So I think our last slide here is a quick summary. So I'll hit some of mine, then Jan and I are going to go back and forth on this. All right. So I'll go first. How's that? Because I'm yakking. The name of this project from the Fed's perspective is Patients Over Paperwork. And in their estimates, it's supposed to save an average of 180 hours per year per doc. True, not true, I don't know, but it feels like it could be true. We feel strongly that this is a change in the right direction, but the proof is in the details. And the details won't hit us until January, February, March. All right, Jan, yours.
That's for sure. If ever there was a time to review and change your EHR templates, this is the one. There are so many opportunities based on these changes for you to avoid note bloat, for you to reclaim the value of your encounters as they're documented. History and physical are yours. They won't be counted against you. They won't be counted for you. The value that they will have goes from billing to clinical, and it's 100% for you. So it's a really nice opportunity to pare those things down, simply because you and any other clinicians that are participating in your patient's care are the only ones those things are going to be for. So this is a good time to make them your own and make them the best they can be.
That was the most important 20 seconds of this entire presentation. Every PCC clients, open up your sick visit templates, and if you don't need it for coding, take it out.
Exactly.
Right? Get it down to what you need to take care of this kid. And you can get a little bit closer to why you actually decided to get into this business.
And what you'd want another clinician to know when if they saw the kid for that problem.
Exactly. All right. So one little curveball for those of you who have work RVU compensation models. This is going to be quite interesting to see what happens. I know a lot of employed physicians are in work RVU compensation models. Your work RVUs on day one, presuming you're using the 2021 codes, our values are going to jump significantly whether or not the revenue you generate goes up. So anyone using a work RVU or even just a total RVU compensation model is going to want to pay attention.
Yeah.
All right, the last two are yours.
All me from here out.
Yep.
The really, really nice thing about leveling by time is that it can be used for any visit. You can use time as the controlling factor, no matter how short the visit, no matter whether the patient or parents or any caregiver involved in the visit that day said 2 words. You can use time. Your own time is what counts. The time you spend before, during, and after the visit on that date all counts into the total that can be used for controlling your leveling for that day. And all visits may be leveled using just 2 out of the 3 medical decision-making sub-elements. So like I said, in future events, I know in particular for PCC clients, we're going to do workshops that help you identify which encounters, in your own words, which elements of your encounters contribute to each of those medical decision-making sub-elements. But in any case, the 2 of 3 rule knows no bounds. It's for every visit that you want to level based on complexity.
All right.
And there we have it.
And if you have questions, there's Jan. She's like, aren't you going to put your name on the slide? I was like, maybe not.
Yeah, that was an invitation that you very, very nicely sidestepped.
The bottom line is, if you hear this, you probably already know who I am. It's Chip at PCC. But Jan and I are both always happy to answer questions.
Very much so.
And we know that this talk has a timestamp on it. This time, we might actually regret some of our statements in as little as as early as next week.
Never.
And so if we need updating, we'll update it. But please send us your questions and we'll be back to you soon. Jan, thank you. I really appreciate it.
Yeah, this was fun. Thanks, Chip.
All right. We'll do it again soon.
Good.